This talk is about Brainstem auditory evoked potentials. It is intended for the clinical neurophysiology fellows at Nicholas Children's Hospital. I will use a practice case as a model for our discussion. The discussion will be conducted using a question and answer format. This case is very interesting. The vignette is short. An 83-year-old man with worsening hearing loss. The brain auditory evoked responses waves are presented in this frame. I will ease you into their analysis with a question. The first question is: brainstem auditory conduction as assessed by left ear stimulation is normal. A true, B false. Please take a look at this frame, stop the video, and give yourself time to answer this question. Once you have reached a conclusion, and not before, roll the video again. The first question we ask ourselves when looking at a panel with multiple brain auditory evoked responses wave is: which one should we analyze first? I like to address this question as well as other questions concerning brain auditory evoked responses interpretation using a master chart. It may look to you very complicated at this junction, but as you will see, it is not. In this frame, I have enlarged the master chart. I will make no attempt to explain it all at once. Its content will be explained to you as we go along answering some key questions. At this junction, I will ask you to look at the top of the chart to where the arrow is pointing. Please take a few seconds to read the steps needed in order to analyze a brain auditory evoked response. Stop the video if you have not had time to read them. As you can see, I have transported these items, that is the item that you have just read, from the master chart to the side of this frame that also has the panels presented in the question. So let's start. The first step is to identify the ear to be analyzed first. Most electrophysiologists start with the left ear, which happened to be the one addressed in the initial question. Remember, S stands for left. Next, you find the vertex ipsilateral ear or ipsilateral ear to vertex derivation. Either will do. Here we have one, and here we have another. Next, we look at those tracing obtained by rarefaction. Here we have one, and here we have another. Next, among those tracing collected using vertex to ipsilateral ear derivation or ipsilateral ear to vertex derivation and rarefaction, we look for the one with the highest dB. This one has 50 dB. This one has 70 dB. So the derivation I have just changed from white to magenta is the one we will analyze first. Next, we need to ask ourselves if the study is good or bad. This is done by comparing the synchronicity of the two averages. Peaks of the individual averages should not be far apart from each other. Here I am looking at two prominent peaks. I have traced a line through the peaks of both averages to better gauge the distance between them. In Levin and Luther's book, the acceptable distance between two averages is 80 microseconds or less. So, if the distance between the peaks is less than 80 microseconds, the study is good. If more than 80 microseconds, the study is no good. Other authors use a less stringent criteria, but not by much, and they consider anything less than 100 microseconds good. This study is good regardless of the criteria used. So, going back to the master chart, you see that the next step is to identify wave 1. How do we do this? By a trial and error process. I like to start by analyzing the first positive wave. So, going back to the frame with the panels, the item signaled by the arrow is wave 1 identification. Here I have indicated the first positive wave. I have now listed under the aqua arrow the steps necessary for wave 1 identification. It is important to stress that the three top items are obligatory. This implies that if one of them is contradicted, the possibility of the wave in question being wave 1 is almost nil. The first item is onset after 1.2 milliseconds. This criteria holds for almost all ages, but in children less than 2 years of age, it must be loosely applied. The onset of a wave 1 after 1.2 milliseconds is absolute in the adult because during the first 1.2 milliseconds after stimulation, the tracing is dominated by receptor potentials. In this tracing, the latency to the suspected wave 1 is 2.1 milliseconds. So, as you see, it is consistent with the putative wave 1 being the real wave 1. The next item is to see that no similar wave is present contralaterally. As you can see, no contralateral wave is present. So this item is also consistent with the putative wave 1 being the real wave 1. Next, a real wave 1 should always be positive regardless of the stimulus polarity. In rarefaction, it is positive, and with condensation, the corresponding wave is negative. The change of wave polarity with a change in a stimulus polarity contradicts the always positive rule. For wave 1. So the analysis of the first positive wave did not cut it. Then go on to analyze the second positive wave. So now that we know that the first positive wave is not wave 1, it is time to start again considering the next positive wave as indicated in this frame. Then the first question is the onset after 1.2 milliseconds? Yes, it is over 1.2 milliseconds. So this item is met. Next item is there are no wave on the contralateral derivation. As you can see, no wave is present contralaterally. So this criteria is also met. Next criteria is the always positive criteria, meaning that it is always positive regardless of the stimulus polarity. During rarefaction, it is positive. During condensation, it is questionable, but it is not contradictory as it was when we were analyzing the prior wave. This is a subtle difference, but it is nevertheless an important subtle difference. So, by the side of this criteria, I have placed a question mark. I have done this to indicate that we are uncertain regarding the polarity of the wave, but that it does not contradict the criteria as in the case of the prior positive wave as we just have mentioned. So, when in doubt, the best thing to do is to keep going down the list. So we continue looking at the other items. We start this second phase by comparing the waves generated by inter-ear derivation with the wave generated by vertex to ipsilateral ear derivations. The wave from ear-to-ear derivation should be of a higher amplitude than that from the vertex to ipsilateral ear. As you can see, the ipsilateral ear to vertex derivation is 0.29 inches as measured by the computer. Remember that when we are comparing amplitude of different waves, it does not matter what units we use to measure them. The amplitude of the wave at the inter-ear derivation is 0.19 inches. So this item does not support the wave that we're looking at being the real wave 1. Next, we look at condensation versus rarefaction. The latency of wave 1 obtained by condensation should be longer than the latency of the wave obtained by rarefaction. So we look at the latency during rarefaction and then during condensation. And as you can see, they are about the same. So this item does not support the putative wave 1 as being the real wave 1. Next, we look to see during condensation if the amplitude of the wave is lower than during rarefaction. The wave during rarefaction is 0.29. During condensation, the wave is 0.1. This item is consistent with the candidate wave being the real wave 1. Next, we ask ourselves if at higher rates the latency is longer. But as you can see, only one rate of stimulation was used in this patient. So this item has to be placed in the unknown column. Next, we see the difference between wave obtained during louder sounds from those obtained during softer sounds. Those with louder sounds should have a shorter latency. This study was conducted using 15 dB NHL, and at that intensity no latency can be established, and thus we need to mark this item as another unknown. The following item has to do with amplitude. Louder sounds make up for waves with higher amplitude. We know that at 70 dB the amplitude of the putative wave 1 is 0.29, whereas at 50 dB it is 0. This finding supports that the putative wave 1 is the real wave 1. So when everything is said and done, the score of the non-obligatory items stands 2 in support of this putative wave being the real wave 1, 2 that do not, and 2 that we cannot tell. So what is next? What else can be done to resolve this issue? And the answer is an electrocochleogram. This electrocochleogram does not belong to this patient. I put it here to show you that brain auditory evoked response wave 1 corresponds to wave N1 in the electrocochleogram. And to remind you that brain auditory evoked response wave 1 is the one closest to N1 wave in the electrocochleogram. Now I want to take a detour. If the first positive wave is not wave 1, what is then the first positive wave in this tracing? Look at the low amplitude used as a reference. This tells you that the overall amplitude of the study is very low. And also notice that there is no stimulus artifact. This is so because the stimulus equipment used to produce the stimulus was a special type of equipment. This special type of equipment, which consists of a stimulator far from the ear and a tube to carry the pressure to the ear, thus producing a delay from the click to the actual stimulus reaching the ear of 0.9 milliseconds. This changes our initial calculation as to the onset of the first positive wave, which is not 2.1 milliseconds after the stimulus, as we initially considered. But it is exactly 1.2 milliseconds after the stimulus. Such a change raises the possibility that this first positive wave represents cochlear microphonics. This is further supported by the wave polarity inversion that occurs during the change in stimulus polarity. So, inversion with the stimulus polarity and occurrence no later than 1.2 milliseconds after the stimulus indicate that this first positive wave in vertex to ipsilateral ear is indeed cochlear microphonic. This ends the tour, and we are going then to continue with the regular explanation by going back to the master chart. So, having determined wave 1, next step is to identify wave 5. And as I did for the identification of wave 1, I will do for the identification of wave 5. Listed under the aqua arrow are the main items that help the identification of wave 5. Again, the process starts by choosing which wave to analyze first. In most cases, the best choice is the first wave that drops below baseline, which I have just identified in this frame. The first item is if it is present after 5.5 milliseconds. This is clearly so. So this item is met. Next item is the one we use to choose the putative wave 5. So it is certainly met. The wave thus crosses the midline. Therefore, this item is met. Next, when different intensities are used, starting at a low dB, we can see that wave 5 is the first one to appear. Yet, no such exercise was done in this case, so this item remains unknown. Next, we look at the difference between inter-ear derivation and vertex ipsilateral ear derivation. Inter-ear derivation has to be lower to support the putative wave 5 being the real wave 5. The amplitude of the vertex to ipsilateral ear derivation is 0.8. The amplitude of the wave in the inter-ear derivation is 0.2. Thus, this item supports that the putative wave 5 that we have chosen is indeed the real one. Next, we look at the contralateral versus ipsilateral putative wave 5 characteristics. The first issue is the better separation of wave 5 from wave 4 on the contralateral side. As you can see, its lateral separation between 4 and 5 is less than the separation contralaterally. So this item goes in the support column. Next item is the longer latency contralaterally than ipsilaterally. So in this case, the latency to the ipsilateral derivation is shorter than the latency to the contralateral derivation. Thus, this item also supports that the putative wave 5 is the real wave 5. This peak duplicity brings about a decision moment, which is which of the two peaks of the putative wave 5 will be used for future measurements. The general rule is to trust the peak found in the contralateral derivation unless you feel very strongly about the peak of the ipsilateral being the one from the real wave 5 and that the peak of such wave has a longer latency than the peak of the wave elicited from the contralateral derivation. So in this case, the peak of the contralateral putative wave 5 will be used for future measurements. Next, we address the issue of contralateral versus ipsilateral amplitude. The amplitude of the real wave 5 from the contralateral side to the stimulation should be higher than that of the ipsilateral wave in order to support the putative wave 5 being real. In this case, the ipsilateral putative wave 5 amplitude is 0.8, while the contralateral is 0.6. So this item does not support that the putative wave 5 we've been looking at is the real one. Nevertheless, despite this last contradiction, I think that there is enough data to support that the putative wave 5 that we have been analyzing is the real wave 5. So we can conclude that the initial selected wave, although with a slight longer peak latency than initially suspected, is wave 5. So now let's go back to the master chart, which you can see here, to indicate that wave 5 was identified. The next step is to determine the 1 to 5 interpeak latency or interval. This is done in order to determine whether the brainstem auditory conduction as assessed by left ear stimulation is normal or abnormal. In this frame, I have reintroduced the original question that probably by now you have forgotten. And also, I have included the normal values for the 1 to 5 interpeak interval. So, the 1 to 5 interpeak interval in this patient from stimulation of the left ear is 3.94 milliseconds, which is normal. So now that we know that the 1 to 5 interpeak interval as determined by the left ear stimulation is normal, we need to ask ourselves if the 5 to 1 amplitude ratio as brought about by left ear stimulation is normal. This is an important point because in the presence of a normal 1 to 5 interpeak interval, the presence of an abnormal 5 to 1 amplitude ratio usually implies axonal damage of the auditory pathway being tested. But in this case, the amplitude of wave 5 is significantly higher than the amplitude of wave 1, the ratio being 2.7, which is normal. So once we know that this ratio is normal, we still need to know one more piece of information before declaring that the conduction through the auditory pathway being tested is normal. But that one piece of information that we need to know would have to wait until the opposite side is analyzed, because it depends on the presence of synchrony between the right and the left auditory pathways. The right and left auditory pathways should be synchronous. A 1 to 5 peak latency with a difference of more than 0.4 milliseconds represents an abnormality in the slower side. So, the answer to this question will still have to wait a little longer until the right ear has been tested, which I will do in the next few minutes. Stimulation of the right ear, remember D stands for right, will allow us to measure the 1 to 5 interpeak interval, that in this case is normal, and to analyze the 5 to 1 ratio, which in this case is also normal, as you can see in this frame. Now that we know that the interpeak latency produced by left and right ear stimulation are normal, we subtract them to see the difference. And as you can see, the difference is within the normal range. So the answer to this question is true. Next question. What is your interpretation? A. Normal brain stem conduction. B. Abnormal brain stem conduction. Take a few seconds to look at these panels. From the prior discussion, you can surmise that taking the same step to identify wave 1 and wave 5 on the right side and making the same considerations when we do so will reveal that the brainstem auditory conduction brought about by right ear stimulation is normal, as pointed out in this frame. So the answer to this question is A. A question worth asking at this point is the following. Is it possible to have an abnormal brainstem auditory conduction despite a normal 1 to 5 interpeak interval, which includes synchrony between right and left side, and also having a normal 5 to 1 ratio? Theoretically, the answer is yes, but it has to be a very peculiar situation. The patient must have a high frequency hearing loss and a very restricted lesion producing minimal slowing of the brainstem pathways, so as to be compensated by the delay in wave 1, which is out of proportion to the delay of wave 5 in patients with high frequency hearing loss. In addition, there must be no significant axonal injury in the auditory pathway in order for there not to be a wave 5 amplitude reduction. So, unless clinically suspected and MRI confirmed pathology is present, a normal 5:1 interpeak interval with a normal 5:1 ratio is synonymous with a normal brainstem conduction in the auditory pathways. Next question. High frequency hearing loss decreases 1 to 5 interpeak interval. A true, B false. Take a few seconds to look at these panels and try to come up with an answer. I hope you got the answer to this question correct, since I gave you the answer just a few seconds ago. I also hope that you recall this figure from a previous video. It depicts the basilar membrane of the cochlea and its relation with the segment of the cochlea stimulated by the different frequencies, cochlear length, cochlear delay, and brain auditory evoked response latencies. All of this is in relation to the generation of wave 1, as you can see in this frame. In a normal patient, wave 1 is generated by frequencies in the 8 to 4 kilohertz, corresponding to an area starting at about 10 millimeters from the start of the cochlea, that corresponds to a cochlear delay in the production of wave 1 of about 0.25 milliseconds, which translate to a wave 1 in the brain auditory evoked response with a latency of about 2 milliseconds from the stimulus. In patients with high frequency hearing loss, wave 1 is generated by lower frequencies, starting further from the start of the basilar membrane of the cochlea, thus producing a cochlear delay, leading to a wave 1 delay. And since the delay to wave 5 is minimal when a patient has high frequency hearing loss, the final result is a shorter 1 to 5 interpeak interval. So the answer to this question is A. Next question. What is your interpretation? A. Cochlear deficit. B. Cranial nerve 8 deficit. C. Conductive hearing deficit. B. Brainstem deficit. To answer this question, I like to go back to the master chart. After concluding that the brainstem auditory conduction is normal in this patient, we need to turn our attention to wave 1 latency. As you can recall, this study was done using a special ear stimulus equipment that do not produce an stimulus artifact, but does produce an additional delay between the stimulus production and the arrival of the stimulus at the basilar membrane of the cochlea. This delay is about 0.9 milliseconds. Adding this delay to the beginning of the tracing in the vertex to ipsilateral ear derivation, we find that the latency to wave 1 is increased in the left ear and normal but borderline in the right ear. So we can consider latency to wave 1 to be increased, at least in the left ear. This finding, in addition to the absence of wave 1 and 5 at 50 dB and their presence at 70 dB, suggests, as you can see in this chart, which is a latency intensity audiology chart, a cochlear deficit. Take a few seconds to review this chart. Notice that the pink band represents the range of normal hearing in perfect conditions and in people with perfect hearing. The cream line inside the pink band represents the normal hearing of most average people. Remember that wave 5 recognition level of 30 to 35 dB above the normal adult hearing level is considered normal. The white line depicts the hearing intensity of people with conductive hearing deficit. The hearing deficit is sustained regardless of the intensity of the stimulus and may not be present at low stimulus intensity. The brown line shows some improvement with increased sound intensity. This is characteristic of cranial nerve 8 deficit. The combined olive, green, and violet lines is characteristic of cochlear deficit. Patients with cochlear deficit may require high stimulus level to generate wave 5, and at a high intensity level, wave 5 latency improves, whereas the latency to wave 1 may also improve, but much less. So the answer to this question is A. In closing, I will use this figure to give you a rundown on the typical findings in brain auditory evoked responses according to the location of the pathology. Normally, latency to wave 1 is 2.3 milliseconds or less, and the 1 to 5 interpeak interval or latency is less than 4.6 milliseconds. When the pathology is above the superior colliculi, brain evoked auditory responses remain normal. When the pathology is in the upper pons or midbrain, latency to 1 will be normal, but the interpeak latency will be increased, or there will be a significant difference from one side to the other. The side with the bigger interpeak latency will be the abnormal side. In the presence of conductive hearing loss, latency to wave 1 will be delayed, but the latency between 1 and 5, that is the interpeak latency, will be normal. In the presence of cochlear deficit, implying basilar membrane pathology, latency to wave 1 will be increased, but the latency between 1 and 5, that is the interpeak latency, will be decreased. In cases of intraosseous cranial nerve 8 injury, latency to 1 will be increased, and often 1 to 5 interpeak latency or interval will be normal. In the presence of inferior pons or intracranial nerve 8 pathology, the latency to wave 1 is usually increased, and so is the 1 to 5 interpeak latency. Thank you very much for your attention.